Hello and welcome to this web presentation on managing patients at risk of falls. It's been loosely transcribed from a presentation given in September 2020 by Catriona Kennedy, the Head of Nursing for Integrated Elderly Community Care. It's for the benefit of anybody who was unable to attend the original lectures. Within our trust, we care for many patients who could be at risk of a fall. This presentation aims to cover who's at risk of a fall and how we can reduce the instances of patient falls using risk assessments and care plans. We will look at new and newly updated paperwork, which you should find on your ward. Why falls? Why focus on falls? Why is it so important that we get this right? We know that if a patient suffers a fall and who, for instance, breaks their hip, a fractured neck or femur, their quality of life and life expectancy is reduced dramatically, and this is unfair. We need to do everything that we can to reduce the risk of this happening. We're not going to be able to stop every patient from falling, but we must be able to demonstrate that we're doing everything in our power to reduce the risk as much as is possible. Can we really reduce falls? Yes, we can. There's an awful lot that we can do if we work together as a team to understand the risks to each individual patient. FallSafe, an improvement project funded by the Health Foundation, aimed to ensure that simple guidelines are implemented in hospital wards to reduce the incidences of patient falls. This graph shows that our falls rate has risen and fallen over the last 3 years, but it does not show an overall reduction in falls. Research has shown that assessments and interventions that identify and treat the underlying reasons for falls can reduce falls by around 25%. This does show that we need to do more. Which patients are at risk of falls? Most falls are caused by the interaction of multiple risk factors. The more risk factors a person has, the greater his or her chances of falling. The risk of falling increases significantly with age, so over 65, many will have a degree of frailty associated with their condition. However, there are also many patients who are considered frail and are under the age of 65. Those with neurological conditions, multiple sclerosis, stroke patients, they're also at risk of falls. Any patient who you think may be at risk of a fall, you should screen them. We screen anyone over the age of 65, always, and anyone under the age of 65 if they show any degree of frailty or have a pre-existing medical condition that predisposes them to a degree of frailty. The Falls Risk Screen. This guide should be familiar paperwork. It takes you through 6 yes or no questions. Was the patient admitted due to a fall? Has the patient fallen in the past 3 months? Has the patient fallen since admission? Does the patient try to walk alone but is unsteady, unsafe when walking? Is there a history of confusion, dementia, delirium, or any condition that would increase their risk of falling? And does the patient have a fear of falling? This last question is deceptively important, as we do know that a fear of falling can actually increase the risk of a fall. If you answer yes to any of these questions, then you must complete the Falls and Fracture Risk Care Plan. It's important to remember that the patient should be screened within 6 hours of admission. You review it at least weekly or when the patient condition changes or they move to a different ward or department. The Falls and Fracture Risk Factor Checklist Stroke Care Plan. This has increased a little bit and is now a double-sided document which prompts you to answer yes or no to a number of questions about your patient, including their vision, medication, postural hypertension, toileting, mental capacity, mobility, footwear, hearing, and bone health. The Falls Datix. There's an appropriate acronym that we can use to look at our falls data. SPLAT. S is for symptoms. P is for previous falls. L is for location. A is for activity. And T is for time. It's very important to capture details in the Falls Datix so that we can learn how to improve individual clinical areas. Post-fall record. To ensure immediate post-fall assessment, this must be completed at the time of the patient falling by the registered nurse in charge of the patient. Section 1. It's important to record the patient's baseline before the fall so that any deterioration related to the fall can be identified. Section 2. Checking for injuries. Harm levels can sometimes be difficult to understand. If you refer to the policy 075, which is available on the intranet, it gives you a risk matrix to help you quantify and categorise harm to the patient. Fill out all sections. Should you answer yes to any of the questions in section 6, red flags, you must refer the patient immediately to a doctor for review within 30 minutes. Neurological observations. There is a national standard for neurological observations that is dictated by the NICE guidance. It says that we should be recording observations for our patients every 30 minutes until the patient's GCS score is 15. The minimum frequency of observations for patients should be as follows: half hourly for 2 hours, then 1 hourly for 4 hours, then 2 hourly thereafter until the patient has been reviewed by a senior clinician. The minimum frequency regimen for neurological observations must be followed irrespective of the time of day. This does mean that if your patient is sleeping, you will need to wake them. Should the patient's GCS deteriorate at any time after the initial 2-hour period, observations must revert back to being taken every half hour and the senior clinician notified. Any of the following examples of neurological deterioration should point urgent action: new onset of agitation or abnormal behaviour, any drop of greater than or equal to 2 points in GCS score, development of severe or increasing headache or persisting vomiting, new or evolving neurological symptoms or signs such as pupil inequality or asymmetry of limb or facial movement. New, Bed Rails Risk Assessment. This is a clear and succinct paper to aid you in your risk assessment. Decisions about the use of bed rails must be made on an individual needs-led basis, but in general, if the statement that applies appears in the green box, then bed rails should be used, and if the statement that applies appears in the red box, then bed rails should not be used. Something to remember here is that if a patient has a degree of cognitive impairment and you choose to use bed rails, you must back this up with a Declaration of Liberty Statement application. How to take a standing and lying blood pressure. There's information online from the Royal College of Physicians, Falls and Fragility Fracture Audit Programme. There is also a very useful video made by the United Lincolnshire Hospitals. I'll attach the link below. You're welcome. For further information and to obtain leaflets for your ward, please visit the Royal College of Physicians website at www.rclondon.ac.uk. Thank you and stay safe.